Welcome everyone. Today we're here for the Society of Thoracic Surgeons Congenital Heart Surgery Database monthly webinar. Today is Tuesday, February the 15th. Hope everyone had a happy Valentine's Day yesterday and got some chocolates. So let's see here. On the call with me today, we have from STS, we have myself and Carol, we have Addie Dolan, we have Emily Conrad. I think that's it from the STS side. We have from our core group, we have Chastity for education today and Leslie. And from the IQVIA team, we have Joe, Jean, Marjorie, and Michelle. Melanie is enjoying a much-deserved vacation this week, so she is not on the call today, but her IQVIA teammates are covering for her. So let's hop into our agenda. Again, I just have a very brief STS update, and then I'll turn things over to Chastity to provide our education for this month, followed by a brief IQVIA update, and then, as usual, we will end the call with your user feedback. If you have any questions, please be sure to put those questions into the Q&A and not the chat. So we'll address your questions once at the end of the presentation here today. All right, for our STS updates, February training manual is available and has been posted out on the STS website. 2021 harvest update. I know many of you are asking when that data is going to be back. The data is currently in analysis at DCRI. That inbound file is expected back from DCRI at the end of this month. So as long as everything continues to go according to plan and IQVIA, gets the inbound file, analysis results are expected to be available to you all mid-March. So with that being said, the spring 2022 harvest update, you'll notice that we have made a revision to the current schedule. We have pushed back the harvest close date for spring 2022 to April the 8th for a harvest close date. So that'll be Friday, April the 8th. And the opt-out date will be Tuesday, April the 12th. Official communication will be sent by STS by the end of this week. So that will be coming again from STS DB by the end of this week. 6.22 data version upgrade. Of course, as you all are aware, specs were sent to the vendors. The upgrade webinars are currently underway. We have been conducting DCF walkthroughs, and you all have had the opportunity for questions. Our next webinar is scheduled for February the 22nd at 12 p.m. Central Time, and we are slated to cover the pre-op labs through the diagnoses. And just a reminder, those data, the draft data collection forms are posted out on the STS website for you to download. There are PDF versions as well as Word versions for you to download. So again, those are available to you out on the STS website. Just a review of the 2021 and 2022 analysis updates. You all are very familiar with this. The 2021 analysis will implement 341. The more granular codes will be implemented into analysis. The 3 additional rules and exceptions will be implemented. And then with the spring 2022 analysis, the updated stat scores will be implemented. These updated stat scores will be applied to the entire 4-year analytic period, and this will include OR dates of January 1, 2018 through 12/31/2021. That's all for myself and the STS updates. I'm going to turn things over to Chastity for our education for the month. Chastity?
Great. Thank you, Leanne. So today we're on the webinar, we are going to discuss some procedural related definition updates. And with each of these updates and clarifications, I will also provide you with the information for next steps and what you should do, if anything. So we'll start with pericardial drainage procedures, and then go through some PA banding clarifications, as well as clarify interrupted aortic arch with VSD repairs. Next slide. So we're going to start, as I said, with the pericardial drainage procedures. Next slide. Okay, so as you know, procedure 920, pericardial drainage procedure, is currently defined in the training manual as listed on the slide, and I don't think I need to read it to you. But as you also know, there's an additional clarification for how to code the op type. And essentially, if you're doing this type of procedure, a pericardial drainage procedure for or related to cardiovascular disease, we're coding this as no CPB cardiovascular. And if you're doing this procedure for cancer, then it's op type thoracic. Now, obviously, we've come across, some of you have submitted questions to the core group about what happens if we do a pericardial drainage procedure on a patient that doesn't have cardiovascular disease, but also doesn't have cancer. And so we don't have a caveat or a clarification for that. So next slide. So we have addressed this, and it went all the way to the task force level on how to look at these procedures. So the current definition will remain the same, and then we're going to provide new clarifications to the op types. And this I am going to read to you. When isolated pericardial drainage procedures are undertaken as part of or as a direct result of an intervention to address congenital or acquired heart disease, this will also include heart failure. The operation type for these isolated pericardial drainage procedures should be categorized as CPB or no CPB, however your surgeons have performed them, cardiovascular procedures. In all other instances, isolated pericardial drainage procedures should be categorized as thoracic. So in other words, op type thoracic. Next slide. So what does this mean for you today? So the STS has made a definitional change to the definition of pericardial drainage procedures. This definition then is going to be applied as of surgery dates from February 1st, 2022 forward. So any operations that were done prior to the operation date of 2/1/22 will be coded per the original definition. So you're not going backwards and recoding anything in your file. As of 2/1/2022, you can start coding those procedures as op type thoracic if they meet the criteria. So next slide. So let's go through a couple of examples. These come from you. These were submitted to the core group and we've answered them. And so I want to provide answers now to everybody in this forum. So post liver transplant on 2/3/2022, a patient returns to the OR with bleeding. The cardiac surgeon is called to the OR to perform a right atrial repair related to central line insertion during the transplant. What is the op type? So the op type for this scenario will be thoracic because the cardiac surgeon came in to repair something that was not related to congenital or acquired heart disease or in the management of heart failure in a patient. And the surgery date is after the effective date. So it's after 2/1/2022. So it occurred on 2/3/2022. And so in this scenario, the op type would then be thoracic. Next slide. So in this scenario, a patient presents to the cardiac ICU on February 1st, 2022 with acute onset dilated cardiomyopathy. While awaiting their heart transplant, a large pericardial effusion is drained with CPB on standby. So what is the op type for this case? So in this scenario, this op type will be no CPB cardiovascular. The pericardial drainage procedure was completed to manage heart failure in this patient. This procedure was done without bypass because bypass was on standby. And in this scenario, the date of surgery has no bearing on the op type because it was done to manage heart failure or a cardiac patient. So no CPB cardiovascular is the answer for this. So next slide. Okay, so now we're going to go into some clarifications for PA banding procedures versus hybrid approach stage 1. Next slide. So as you know, we have a couple of ways to cover PA banding in the procedure codes in the congenital database. So first off, we have procedure 1640, PA banding. And the definition for this is placement of a pulmonary artery band of any type. So it doesn't specify that it's only a main PA band. So any type would mean that it can be a bilateral band, it can be a unilateral band, or it can be a main PA band covered under this definition. Then we go on to have procedure 2160, which is hybrid approach stage 1, where you apply left and right, so bilateral PA bands. And the definition really goes in to define what is a hybrid procedure versus hybrid approach. And so I think what I would say for the core group is that we probably made some assumptions when answering the previously submitted questions to the core group, thinking that everything was falling under this hybrid approach, and really it wasn't. So I think that was an assumption on our part, and we now understand that we definitely needed to clarify what should be included under a hybrid approach stage 1. So next slide. So what's going to happen starting, well, we're going to go backwards, but anyway, what we're looking at is for procedure 1640 PA banding, the definition will remain unchanged. For 2160, a hybrid approach stage 1, application of right and left PA bands, we're going to clarify this definition. And to use the hybrid approach, we really want it to be a hybrid approach. It does not mean that you have a surgical or cath-based technique used in the same operative setting on the same day, same time, but essentially it's a combination of techniques to achieve this end goal. So what we're looking at for a hybrid approach stage 1 will mean it is for the application of bilateral pulmonary artery bands with a ductal stent to maintain patency, or the concomitant use of PGE to maintain ductal patency. So either way, this is where we're looking at that constellation or combination of techniques to achieve the palliation for the patient. So placement of bilateral PA bands does not necessarily mean it's a hybrid approach. Next slide. So what's going to happen here is we're going to definitely update the training manual to clarify this definition. So that will go out in it'll be early March. And then recoding of data. This is going to be the question that you all have for us. Can we recode our data? So we look at this and we know that there's a small number of procedures that are likely coded incorrectly, where perhaps you have coded a hybrid approach when in fact you should have coded 1640 PA banding. This is likely small. And so it is a site-specific decision if you want to go back and recode your previous procedures or look at those procedures. So you don't have to do it. The STS is not forcing you to do it. So it really is up to you, or perhaps your surgeons, if you think that it's in your best interest to go back and do this. Next slide. Should you be a site that would like to recode your PA banding procedures, there are multiple ways to get to your data so that you can look into this, but you need to be able to identify operations where the primary procedure is 1640 PA banding or 2160, a hybrid approach stage 1, if you want to make sure that you have your PA bandings coded appropriately versus your hybrid approaches coded appropriately. And then you want to review your clinical documentation and look at the patients to see if they have an existing ductal stent or PGE. And there are other data points that you may have collected in your database already, such as that anesthesia collects preoperative and intraoperative meds. So that's one easy place to go look if you do the anesthesia database. Did I code PGE? Was the patient on PGE when they entered the OR? So that is definitely one easier way to do this as well. If you need any help, you are so welcome to reach out to me. You can submit an FAQ, but obviously I know that might take a little bit of time to get back to you. I'm sure other members of the core group, I'm going to put Leslie's name out there because she's on the call and she can smack me later, but I'm sure she would be happy to help you as well. We all use different software packages and things, and there may be reports within your personal software that I'm not aware of that could get you to this easier. Again, it would be a very small number of procedures that would require recoding, and perhaps you've done this correct from the get-go and you don't have a lot of recoding, but you're always welcome to go back and look and make sure that you've done this accurately. So again, think this through, and you're welcome to reach out to me or to any of the core group members or submit an FAQ if you have further questions about how to recode these, if you should recode these, and what the thoughts are behind that. All right, so for 6.22, some of this, the good news is, will go away. We're going to have some new and changed procedure codes that will help cover these scenarios. So 1640 is going to be changed, and it's going to be PA banding placement of a main pulmonary artery band. Then we're going to get a new code, and I apologize that I did not include the new code's number, but I have it somewhere at 7860. And this will be PA banding, placement of unilateral or bilateral branch PA bands without the need for concomitant PGE or a ductal stent. So now you'll have a new code that you'll be able to use for that scenario. And then now we're going to change 2160 to say application of right and left PA bands with concomitant PGE to maintain ductal patency. And this will also include a ductal stent as well. So this will not happen until version 6.22's go live. And I think the important thing is when 6.22 goes live, it'll be from that surgery date forward that you can use the new codes. You cannot, even if your software allows you to do this, you cannot go back and recode the operations prior to the 6.22 go live using these codes. They won't be analyzed appropriately. All right, so let's go through a few scenarios. Should all bilateral PA band placements be coded as 2160 hybrid approach stage 1 rather than 1640 PA banding, regardless of the patient's anatomy? And the answer here is, I hope that you had this in your head already, is no. If there was concomitant use of PGE or a ductal stent, then the procedure can be coded as a hybrid stage 1. If there was not concomitant use of PGE or ductal stenting, then the procedure should be coded as 1640 PA banding. If a patient undergoes right and left PA banding surgically, but ultimately goes down a 2 ventricle pathway, should the procedure be coded as PA banding or a hybrid approach stage 1? And this really depends clinically as to what's going on with your patient or how they're being managed at this time. So again, same answer. If there was concomitant use of PGE or a ductal stent, the procedure will be a hybrid. If there was not concomitant use of PGE or ductal stenting, the procedure should be coded as 1640 PA banding. And of course, these examples are for our current version, our current data specs, and these answers would change when we get to 6.22. Okay, so now we're going to move on to interrupted aortic arch and VSD repairs. Next slide. As you know, currently what is stated in the training manual is the interrupted aortic arch repair does not include repair of interrupted aortic arch repairs plus VSD repairs. So our instruction currently in the training manual is to code procedure 1285, aortic arch repair plus VSD repair. This was brought up, I believe it's 2 AQOs ago, and it was discussed at AQO that this is not how we want to do this and that we should actually be reflecting the fact that we are repairing an interrupted aortic arch and use that code. However, the training manual post AQO did not get updated, and so we are going to take the opportunity to do that now and set this straight. So next slide. So when you are doing an interrupted aortic arch repair, along with a VSD repair, we are going to code 1320 interrupted aortic arch repair as the primary procedure. You will code then the VSD as a secondary procedure. And then again, because this is a clarification to a definition, it's really up to you as an institution if you want to go back and update your previous operations. The training manual will be updated again in first week of March. It will be released the updates will include changing the definitions to the interrupted arch repairs, as well as going back to the aortic arch repairs, which state to code this if you've done it with a VSD repair. So both of those will be updated. I will also make sure that any outstanding FAQs, that the answers are struck through so that those aren't confusing. I know that that's been a concern sometimes when we provide clarification that we don't go back and update those answers. This will get better, and especially as we go into 6.22 and we post our questions in a different way. So I believe that's my last slide.
Yes, ma'am. Thank you so much, Chastity. Appreciate it. So we've got some questions coming in, so we'll tackle those. Let's hop over to the IQVIA update, and then we'll tackle our questions. So Joe, the floor is yours.
Thanks, Leanne. Good afternoon, everyone. I don't really have any updates for you today. The items on our list are items that we've presented the last couple of webinars, just letting you know that these are still in the works and we are going to get these updates out to you. These are the updates that are coming for the primary procedure mismatch report to include those additional exception rules. So you can see those on the current slide. There is one additional slide to correct an issue with the risk adjusted report for table 21. So the results will be removed for procedure codes 1275 and 1285. But again, nothing new here, and we will get these out to you as soon as possible.
Great. Thanks so much, Joe. I appreciate it.
Yep.
All right. I'll run through these final slides rather quickly. I see questions are starting to come in. So again, if you have any questions regarding your report or the dashboard, please reach out to IQVIA Tech Support at CHSD Tech Support at IQVIA.com, and STS and DSR will be looped in, excuse me, as needed when tickets are escalated. Next, my contact information is here. Again, please feel free to reach out to me at any time with any questions, concerns. Also, Database operational questions, please reach out to stsdb@sts.org for questions regarding your contacts, participation agreements, payments, all that fun stuff. So please reach out to Addie and Jane at stsdb@sts.org. Also, if you have questions regarding access to the platform for any of your surgeons, email Addie and Jane at stsdb. Upcoming webinars, just please be sure to mark your calendars accordingly. Our next monthly webinar is scheduled for March 15th at 12 p.m. Central. And then our next upgrade webinars, I believe we have one next week, coming up next week on the 22nd at 12 p.m. Central, March 1st, and then March 8th. So those are our next webinars coming up. All right, so next let's tackle your questions. I see there's several coming in, so let's go ahead and get started. Our first one from Dita. What will the stat categories for the change codes? What will be the stat categories for the change codes, the new code for PA bands? I don't know that off the top of my head. Dr. Subramanian, do you happen to know that off the top of your head?
It will have the same stats category as the PA band. That has been the long-standing STS approach. That is when we have more granular codes, until those more granular codes are coded for enough period to have their own stat score. Until that point, we just borrow the stat score of the less granular code and use it. So the change code for the unilateral or bilateral branch PA bands will have the same stat category as the main PA band, which is stat 4 as of now.
I think Becky just wanted to confirm a truncus arteriosus who undergoes palliation with bilateral PA bands and a PDA stent or left on PGE should be coded as 2160 with the current codes. So it looks like Becky was just making a clarification there. I don't know if anyone had anything to add there.
No, that confirmed.
Okay.
Yes.
Perfect. All right. Let's see here. Our next question from Maggie. Does the patient need to remain on PGE after the PA banding in order to use hybrid approach or just be on PGE at any time of entry into the OR for the PA band?
Dr. Subramanian, do you want to take that one?
Absolutely. They can be on PGE. They should be on PGE around the time of requiring the PA band. In other words, we're going back, and this is the point that Becky was also making. We're going with intent here. If the idea is to ban the PAs, but maintain systemic circulation with the ductus, either with pre-existing PGE or a ductal stent, we want that to be coded with the hybrid code. So it doesn't have to be PGE started at the time of entry into the OR. If they have been on PGE before and they continue to be on PGE during and after the PA band, you should still use the hybrid code.
All right, our next question from Jennifer. If these 3 new rules are being applied to what's currently being analyzed, why were we not made aware of this prior to harvest close so we could fix them? Are you going to let us know how many of our submitted procedures fall into these categories, i.e. what procedures are miscoded? So just to clarify, the 3, because there was a question from Kelly in the beginning. So let me backtrack to Kelly's question that I had answered. Kelly had asked, the 3 new rules will be applied to what time frame? So the 3 new rules that we have covered in previous webinars are being applied to the data that are currently in analysis. And the 3 new rules that we are referring to are regarding the ones that we reviewed regarding the Glenn and Hemi-Fontan procedures, as well as the PA construction, and what was the other one regarding? It was the
pulmonary valve replacements and Ross procedures with conduit placements.
Right. So those are the 3 new procedures that the 3 new rules that we are referring to. And again, we had covered those in previous webinars. So I just want Jen, or were you aware those were the specific rules that we were referring to, or did you think that there were other new rules that we had not previously discussed? Oh, you thought she was referring to the ones that Chastity just went over. No. So I was referring to the previous ones again that we had discussed on previous webinars. So, but A question from Krista. Why is it an institutional decision to update historical operations with these clarifications, but not for the pericardial drainage clarification?
Let me take that, Leanne. Krista, that's
Sure.
an excellent question. That's a really good question. And I'm going to do my best to try and understand the thought process from STS on this. I will preface this by saying we've spent a lot of time trying to understand how the STS talks about, within air quotes, recoding data. The fundamental driving principle is the following, and that is we want to harmonize the way things are done between the various databases: adult cardiac, general thoracic, congenital, and the PDMAX, the INOMAX database, the aortic database. We want to harmonize how we do this across the databases. So the policy decision that STS has made is as follows. If we are just clarifying a pre-existing rule, that is, the rule has always been intended a particular way, there may have been coding differences because the rule was not explained or interpreted correctly. If that's the scenario, and the explanation there is for the PA band example that Chastity gave, if all we're doing is clarifying a pre-existing rule, but not changing a pre-existing rule, we're going to leave it up to the institution, because that follows in line with the institution trying to interpret the codes to the best of their ability and coding it into the database. So we trust that every institution, every data manager, every participant, every surgeon is going to put their best foot forward to continue to code based on clarifications we've provided to pre-existing data collection fields. So those we're going to leave up to the participant. When the database, when STS, the database and the task force make a conscious change in the rule, we feel that the best way to keep equity between all the programs is to say, we made the rule today, starting today, this is how we're going to code, and the way things were before, please leave it be. Because that eliminates inequalities between programs. Some programs may have a lot of cases. Some programs may have a lot of resources. Some programs may not. Some programs may have the time. Some programs may have the capability. We want to eliminate all of those differences. So if the STS makes a policy decision coding change, we believe that that should only happen from the date that change was made. And the most classic example for this is a data collection form upgrade. Data collection form upgrade starts on a particular day. And like Chastity said in today's call, and as we've always said in the past, you cannot go back and recode your data for previous DCF versions. It starts today. So that's sort of where the STS is going. I recognize how the lines may seem blurred to you, but it's a conscious decision we're making because we want this to be as equitable across all the programs as possible. And we also want to keep it uniform between the various databases, as some of you data managers who may be coding for two different databases know that there are differences between the databases, which we don't want them to persist as policy differences. So to summarize, if it's a pre-existing rule and just a clarification, we're going to leave it up to the participant. If it is a rule change coming from the STS, it will be implemented from the day the rule change is rolled out. I hope I made that clear. Leanne, back to you.
Yes, thank you very much. Perfectly clear. Greatly appreciate that. Next from Ruthie, was there any discussion to adding interrupted aortic arch and VSD repair in version 6.2.2?
Yeah, that's a good question, Ruthie. There was unfortunately not. So we have a plan to take it up with the task force, Ruthie. We will find a way to see if we need to do this at the analytical level or not, depending on what the outcomes and the numbers are for these procedures. We will address it somehow for this 6.22 version. And Leanne definitely has it in her list for our next upgrade, which, as you know, will be within 3 years.
Yep. Add it to the list. Our next question from Michelle. We're coding our current data for PA band versus hybrid stage will impact our US News World Report data. What do you recommend?
Hi, Michelle. My personal recommendation is you want accurate data reflected in the STS database as accurate as coding it as possible. And so with that, you would want to have the appropriate coding of a procedure that is truly a hybrid, and that is not a hybrid as PA banding. But that being said, if you're going to be a program that decides not to go back and update your data, then that's okay. I also think US News is due here at the end of the month. And so if you've already turned in that information to your hospital administration, mine is frozen and I can't make any more edits is what they've told me, despite the fact that I keep beating their door down. So that may just be, done. However, when I look at the question for US News, it is specifying that you've done a hybrid or a Norwood repair for patients with HLHS only. I don't have any scenarios where we did bilateral PA banding for a patient with HLHS that didn't already have a PDA stent or wasn't on PGE. So, because I've already looked at my recoding, and so for that, it did not change my US News data at all. And so just because I think it is at the question specifically this year asks for only HLHS patients in that question.
Thank you, Chastity. All right. Our next question from Krista. Did an email ever get sent out to hospitals about the stat score changes? Not sure if I missed it. So I was, Dr. Subramanian and I have been discussing this and talking about sending an official communication, as well as we are going to be having a surgeon webinar coming up soon to discuss the 6.22 upgrade. And we are also going to discuss the implementation of the updated stat scores in that webinar. So Dr. Subramanian, did you have anything else that you wanted to add about our 2020 stat score updates communication?
No, Leanne, you said it right. We will get to the surgeons for sure. We're definitely planning on it. It's not only going to be an email, which obviously has to go through the marketing of STS. Mm-hmm. Like Leanne said, we will address this in a specific webinar where we're going to talk about the two big changes that are coming in 2022. You all have my contact information. You're welcome to give it to your surgeon colleagues. I will gladly talk to them offline as well. The paper is now published. It's in the public domain. We'll circulate it. We will make sure that there is plenty of documentation, information sharing, and explanations with your surgeons. We will not leave you hanging. I assure you that it's coming.
I'm sorry, I did not see. Kelly, I just noticed that your hand was up, so I apologize if you've had your hand up for a little bit. Let me unmute you. Kelly?
Hi, so you'll communicate this to the surgeons on a webinar, but are you going to send something out in an email? Yeah. There are other people who are very interested in this information besides just the surgeon leadership.
Yes, we are going to send an official communication as well, in addition to the surgeon-based webinar that we will have.
Okay, and do you know when that? Can you give us a timeline for that?
I have to work through marketing. Unfortunately, it's not, I wish I could just type it up and send it out, but it does have to go through various channels within our marketing department to get approved and to be sent. I do not know what marketing's timeline is, but I can reach out to the marketing team to see what kind of lead time they need to get that official communication out. And so I will work with them and get an update for you. But obviously the plan is to get that out sooner rather than later. We know you all, your leadership is wanting information on this. So we will work to get this out, and I will work with marketing to see what time of lead time that they need before they can get out this communication.
Okay.
Yeah, but it has to go through several steps. So just to keep that in mind. So, but we will definitely we are working on it, Kelly.
Okay. I know that we've been asking for it for quite a few webinars. And I would have anticipated that it would have been out by now, but
okay.
Thank you.
Okay. All right. Next question from Dawn. Where on the website can a new data manager find a concise list explanation of the 3 new rules? So I will be updating the STS website. As always, the rules have always been listed in the analysis overview when the reports come out, as currently is the way that things always have happened. When this fall report comes out, the analysis overview will be updated accordingly for this fall report, and these new rules and exceptions and everything will be updated in that overview document to go along with the newly released report. Next question, vendors are telling us that they have only received partial specs for version 6.2.2. Is that true? The vendors have received the data specifications, the data specs that they need to build the new upgrade. So they have all the complete data specs in their hands. The software specs are coming, I believe Paul said this week. So the software specs are on the way. They do not need the software specs as well as the data specs to complete or to begin reviewing to look at the data spec bill, but so they do have those data specs in their hands for review, and the software specs are being sent, I believe Paul said, by the end of this week. Don't quote me on that. So I don't want to get in trouble with Paul, but he is working on them and they are coming very, very soon. Will the 3 new rules be incorporated into rules to determine primary diagnosis and primary procedure document? Yes. So as I just mentioned, so those new rules will be updated in the analysis overview documentation that goes along with the release of the report. So yes, ma'am, that will be included in that analysis overview documentation. Let's see here from Becky. It looks like with the new 2020 stat scores, 2160 will be a stat 5 and 1640 remains a stat 4. If the cases are coded incorrectly, it may change analysis of expected outcomes when the new 6.2.2 code is implemented. What will the stat score be for the new code?
I'll take that.
Yes, sir.
So the new code, Becky, is going to be a more granular code of 1640. As you saw from what Chastity told us, it's only going to be for the main PA band. You can either choose that as a main PA band or PA banding of unilateral or bilateral PAs. In other words, we're adding the more granular code only for the PA band that will not have concomitant PGE or PDA stent. So that code, because that's a granular code of 1640, will live with 1640 and be stat 4. Will live under 1640 and be a stat 4. 2160 is the hybrid code, which I think you're mentioning, that becomes the stat 5. We're only clarifying it. We're not adding a code to it. We're just clarifying it to state with the concomitant use of PGE or a PDA stent to keep PDA open.
Can you please restate the close date? I should have just gone the other way. Sorry. It's April the 8th. Sorry for the fast scrolling. April 8th is the close for the spring 22 harvest. Opt-out is April 12th. Chastity, will the training manual be updated with the clarifications on the procedures you discussed this morning, and could you share your slides?
Yes, so all of this talk is recorded and will get posted, as well as, don't the slides get posted out under the webinars as well? Leanne, am I mistaken about that?
Yes.
Okay.
Yep.
So yes, those will get, and it comes faster than I even imagined. It's usually within like 7 to 10 days that it gets posted out there.
Diane, would it be possible to add the changes to rules to the FAQ training manual? Are you talking about the new rules exceptions, Diane? Excuse me. But we would not know the rules. If you're talking about rules and all of that, that would not go into the training manual. We would put that information out on the STS website in the analysis overview, but all the rules and changes to rules, exceptions, that all goes in the analysis overview and not the FAQ training manual. We do not have the list exception of the 3 new rules yet. Correct. Did I understand that correctly? And to clarify, they are being applied to the previous harvest that is currently in analysis. So those 3 rules exceptions that we had covered in previous webinars are being applied to the fall 2021 data that is currently in analysis. They will be included in the analysis overview that will be posted along with the fall 2021 harvest results. And we covered those, I believe, in two other webinars, the 2 previous webinars. So those are out on the slide deck if you need to go back and review those, Brooke. But of course, they will be also included in that analysis overview. Is there an existing document that lists the old stat score category alongside the new stat score category for each procedure? When the analysis, the updated Appendix C is posted and available for you all, that will be coming within the next few weeks, coming soon prior to the harvest close. The appendix, the way I've done the Appendix C, it does have the old stat score alongside the new stat score. So you will be able to see the old score versus the new updated score. So that will be available to you all. Let's see, could there be a rule section in the training manual? Could this include the 3 new rules, including the Glenn? Now, we're keeping the rules exceptions in the analysis overview document. That way we have one source of documentation, one source of truth for those rules and exceptions. So all of the rules and exceptions will be placed into the analysis overview. And then the training manual will be focused on the FAQs and intent clarifications for all of our variables.
Leanne, if I could tag on to that a little
Sure.
bit, I think one way to kind of frame this in your mind is that the training manual is really set forth for definitions. What is the definition of that? When do I code this? And that kind of information, versus the rules are really about analysis and how something's going to be analyzed and how it should be analyzed. And so I think that that helps me keep it straight, that when it's something that pertains to the analysis or how something should be analyzed, I want to look in that specific document, whereas the training manual is where I go for a definition. Does this meet the criteria to be a pericardial drainage procedure where I'm going to use op-type thoracic or where I'm going to use op-type something else? And so we really are making a concerted effort to keep those separate. And so I don't think that they go in one place together.
Perfect. Yeah, thank you for explaining that a lot better than I did, Chastity. I appreciate that. So IQVIA, so next question from Liz. IQVIA is updating the stat scores for the spring 2022 harvest. So yes, so as we have stated, the spring 2022 harvest will include the updated stat scores. IQVIA is in the process of updating the primary procedure mismatch report to reflect those new stat scores, the updated stat scores. Once IQVIA is ready to, which they are working on, once they deploy the updates to the primary procedure mismatch report, we'll have the Appendix C available to you all. So there will be a communication to you all once IQVIA has the primary procedure mismatch report ready for you all to submit. Also, that is another reason why we have pushed back the close of the spring 2022 harvest date, because you all need to have ample time to submit your data to IQVIA, get that primary procedure mismatch report back to make sure everything's looking like you expect. So again, we will be communicating to you when those primary procedure mismatch report updates are deployed into production, and you can begin to submit your data looking at those with those new rules implemented, those new stat scores implemented. But all those rules, so from Joyce, but all of those rules are used to actually know how to code your primary diagnosis. It's frustrating to have to go to different sources to enter data. I understand, I hear what you're saying, but I think Chastity, it's easier to have all of this information, the analysis, how the analysis done, the rules that affect the analysis or impact analysis are housed in the analysis overview document. And as Chastity had explained it, the training manual is more for definitional changes and definitional clarifications. We really have to keep these separated and have that one source of documents so we can make sure updated in one place and things, so we don't have different documents that perhaps have not been updated at the same time. So it's nice and easier for us to have those analysis rules and clarifications in the analysis overview, definition, clarifications, updates in the FAQ training manual.
And Leanne, I agree. I think it would be more frustrating to have 2 documents that haven't been updated at the same time, which is what would happen between those 2, because you're updating one at the time of analysis or at the time an analysis has been done or is being done, and the other would be updated monthly. And so I think that they would always be out of sync, and that would be problematic, more problematic than having 2 documents.
Yes, and Dita, can you please repeat the 3 rules? Sorry, nope, I don't mind. I'm going to pull this document over for you. So think you can see this, but so from the December task force, these were the changes. These are the 3 new rules that that are being implemented in the fall 2021 harvest, currently in analysis. It's if any multiple component operation that includes one of the below named blend or hemifontan procedures listed here, and also includes any of the following listed here, then the primary procedure will be determined to be the pertinent one from the second list of procedures and not one of the Glenn or hemifontan procedures. The second rule exception change is if any multiple component operation that includes one of the below named PVR procedures listed here also includes the PA reconstruction, plasty, actually there should be a S team there, and main trunk, then the primary procedure be one of the PVR procedures and not 530. And the third and final one is in the event of the following simultaneous procedure, the 610 conduit placement RVDPA, combined with any of the following 2 procedures, the Ross procedure or the Ross Kono, then the primary comes from the following list as stated here, exclusive of the 3 VSD repairs. So in the latter instance, the component procedure with the highest stat mortality score or procedure from the list above under exception 1 is primary procedure. Next question. Sorry, hold on, I'm trying to get my screens right. Next question, but we don't have an analysis report that is accurate for the month like the training manual is. Okay, I hear you.
Hey, Leanne, it's Leslie.
Yes.
I think there's a little confusion between the document that's called Rules for Determining Primary Procedure and like the training manual or the analysis overview. So after analysis is done, the analysis overview then kind of describes how the analysis happened, and that would include the rules. And then the document that's been available on STS, that's called Rules for Determining the Primary Procedure, is just a copy out of the analysis overview. So maybe that will help.
How's everything libraries? Can you update the documents? We have one source of truth for what the proposed rules will be. The harvest analysis in the library and IQVIA. Yeah, got it. Yes. Let's see. Would you consider putting a link to the primary procedure rules document in the training manual under the prime prop definition? That's a great idea.
That is. So, I think that that would be
a great idea.
And quickly link to that.
Yep. So if we are submitting data for this upcoming harvest, we should not be running the primary mismatch report because the new rules have not yet been implemented on the IQVIA platform yet. Is that correct? So yes, Elizabeth, that is correct. So if you're submitting data right now, the primary procedure mismatch report that is out there right now does not have the new updated stat scores currently implemented. IQVIA is working on the primary procedure mismatch report to update that to include the new rules, exceptions, as well as the updated stat scores. As soon as that has been updated and been deployed and is in production, obviously we will keep you updated on the next webinars to let you know how that is proceeding, and we will let you know as soon as that primary procedure mismatch report is available and has been updated and is deployed out in production. Obviously, the harvest close date takes that into consideration, and you all will have ample time to submit your data to ensure that the primary procedure mismatch report, everything with the new stat score is how you expect it. So there will be plenty of time for you all to submit your data with the new stat scores and the primary procedure mismatch report implemented. But you should still continue to submit your data and clean up your data and not wait until the primary procedure mismatch updates are deployed. Obviously, we still can encourage you to submit your data and continue to clean that. And of course, once that primary procedure mismatch report is updated, you all will have ample time to get that data submitted and utilize that updated primary procedure mismatch report. Let's see here. Thank you very much for sharing the rules again. You're very welcome, Brooke. I know I watch almost all the webinars, but there's a lot of information shared at each one. I agree. All of the changes going on, it is challenging to keep them all straight. I appreciate the time and work that goes into them. Thank you again for sharing. You're very welcome, Brooke, and absolutely happy to get that for you. When would the harvest analysis overview in the IQVIA library be updated? I am working to get the IQVIA the library updated, get the new rules implemented. I can let you know, it's usually comes out prior, just along with the release of the reports. So that is always updated as soon as the reports are posted. So we're looking to have the reports available to participants mid-March. I can go ahead and get that document updated and available as soon as possible, but I can give you an update on the next webinar and get that implemented. But typically the analysis overviews are released in conjunction with the release of the reports. In the future, can we have a general FAQ document where all FAQs are added? Having the definitions updated in the specs is only helpful if you're actively looking something up.
I'm happy to take this.
Yeah,
Yes.
I was Jess, if you want to let her know what we've got planned for the new and improved training manual.
Yes, absolutely. And so as has been previously stated in previous webinars, that is the plan. We will not be posting every question to the manual any longer. We will only be posting any of the intent and clarifications to definitions in the manual, as I think that will be more useful to everybody. And then there will be a living, breathing document that as we make updates to the training manual, that you can see month over month what was added in intent and clarification. So it won't be the specific questions, but it will be an intent or clarification. So for example, something like the PA banding procedures, we added language to clarify that definition. And so it would go into the training manual, and then I would say, March 2020, or 2022, here are the updates that occurred. And so that will go live with version 6.22.
Okay. Maggie, since the new SAT scores are going to be applied to the 4-year reporting period data, will we have primary procedure mismatches that go through the 4-year reporting period that will need to be updated? Let's see here. Sorry, let me read your question again, Maggie. I apologize. Since the new SAT scores are going to be applied to the 4-year reporting period data, will we have primary procedure mismatches go back to the 4? So, Joe, I don't know if you guys, the primary procedure mismatch report, yes, will go back through the time period that you submit. So you can submit your file. You can look at it based on the time period that you submit. So you can look at it for that 4-year reporting period. I don't know if I'm explaining that very well, Joe. I don't know if someone from your team can clarify that.
I think in essence, if the question is that the primary procedure mismatch report will get updated, the answer is yes.
Yeah, yes. So it will be for all 4 years. So that's what you're getting, the gist of what you're getting at, sorry. Okay. All right. Any additional questions from you all? I know we're just about at the hour. Heidi's typing. I see you, Heidi. I'm holding. Trust me, you guys don't want me to start singing. Okay, never mind, Heidi. And I hear you, Autumn. Okay, got it. Okay. Saw the post about delaying. And Autumn, I think we just want the new rules added to the rules to determine as soon as possible, and not have to wait for the report to come out. I hear you. Understood. All right. Anyone else going once, going twice? All right. Okay. That's all that I have. So thanks everyone for joining today. And if you have any questions, please feel free to reach out to me directly. My contact information, you can reach me at ljones@sts.org if you have any questions or concerns. Thanks everybody for joining today. Dr. Subramanian, greatly appreciate you being on the call today. Having you on is extremely helpful. So we are greatly appreciative for you to take time out of your day to join us for these calls. Chastity, Leslie, IQVIA, thanks everyone for joining today. I greatly appreciate it. I hope you all have a great day.
Thanks everybody.
Thanks.
Thank you.